Cool. So hello, good evening. Welcome to one of the obstetric sessions for K2 training. So what we're going to go over is the incoming IT system. So we switch on next Wednesday. We're going to go through the various different functions and the ways in which you might need to use it. So we're going to look at how you run antenatal clinic. We're going to look at how you do blue box triage. We're going to look at how you do ward round. So whether that's an Argyll ward round, a TCW ward round, antenatal, postnatal, intrapartum, they all work in much the same fashion. So we'll do a bit of that. We'll also talk about triage and how you do a triage review if you're asked to attend there. And then we'll do some of the intrapartum work. So again, we'll have a very quick look at what intrapartum ward round looks like. Also about how to do things like CTG reviews, how to update management plans, how to prescribe and administrate for Synto, and also how to do op notes after delivery.
Francesca, you've frozen.
I came back. How long was I gone for?
It's like someone that's passed out. You were gone, but you were out of it for about 20 seconds.
Well, I'm back. Ta-da!
You slapped me around the face.
I can't die out at this stage. So we won't run through those bits again. But essentially, we're going to cover all the elements of the system that you guys are going to need to use. So just a bit of clarification, an important point is we talk about K2, but K2 actually has 3 different systems. They all work from the same database, so all the information goes to the same place. It's symbiotic, they move between the systems. But you use Athena for antenatal, postnatal functions. You use Guardian for intrapartum. And then there is the patient-facing portal that's called My Pregnancy Notes. And so that is where patients can go in and look at their information. So we're going to start with Athena. I'm going to start at the beginning. Now I have an overview video that I'm going to show you that gives you just a broad notion of what Athena can do. So we're going to start with that one. So to do that, I need to share my screen. Just press that one. So it's got audio, so you should hear audio fairly quickly. If you can't, then shout and let me know. We'll just let this one load.
In this video, we will be outlining the functional navigation of the K2 Athena system. Please ensure that your username and password have both been set up prior to accessing Athena. Upon logging into the system, the first page you will see is the home screen. For ease of navigation, this has been divided into 5 separate tiles. On the home screen, you will also be able to adjust your settings via the Tools wizard. Here, you can view software information, adjust the font to your preferred size, see any updates, view the log file, change your password, check your network connectivity, and view regulatory information. It is important to note, once you are finished using Athena or are away from your device, you will need to either log out, exit, or lock the system. This is in order to comply with information governance and data protection laws. There are various ways that you can find women that have been admitted onto the system. The first being via the Locations tile. Here you can find clinics as well as inpatient wards. In this example, we will look at an inpatient stay and show you how to admit a woman to Argyll. At the top of the screen, you will see the Admit Woman button. Clicking this will take you to the search bar where you can find the woman you'd like to admit, either by inputting their hospital patient ID, NHS number, name, or date of birth. Each woman admitted will have a 3-dot menu where you can select some quick actions that need to be undertaken. Or you can go into the View Full Inpatient mode, and this will include everything that can be entered throughout the inpatient stay in managed tabs for ease of access. These tabs include admissions, management, risk assessments, clinical assessments, observations, specialisms, investigations, fetal assessments, procedures, labor, and outcome. Going back to the home page, we will now look at the teams tile. The teams are separated into different staff groups for ease of access. The first one we will look at is specialist referrals. Behind this screen you will see pending referrals, which the team can either accept or reject. We also have our consultant teams. Here you will see all women assigned to a consultant. Next is the midwifery team. Here you will see all women assigned to a midwifery team. You can also filter the search so that you can see women assigned to an individual midwife. In the Management of Women team, you will see a list of all women. You can filter by teams, assigned midwife, and assigned consultant. There is also a safeguarding team that women can be referred to. The third tile is My Desk. This is where users can go into offline mode, set themselves up a profile, and use the blue drop-down button to view relevant women and appointments. This setting is not dependent on network connectivity and will be used when attending appointments in the community. You will need to ensure that prior to attending community appointments, women have been moved into your offline briefcase. You also need to ensure they are removed from the briefcase afterwards. Next to My Desk is the Quick Tasks tile, which can be used for a new booking or to enter delivery information. For a new booking, once you click the button, you will have the option to search for the woman you would like to book. You can do this by inputting her hospital patient ID, NHS number, first name, surname, or date of birth. The final tab on the home screen will be mainly used by admin staff and team leaders. Here they can create custom reports from data that has been entered into the system. Here you can see the search button. We will now use this to search for an example woman. Please note these are test patients and we will not be using real patient data. Once you have searched for your patient, the system will ask you to confirm that you have selected the correct person. You will need to check and select yes or no. This will take us into their main notes. The main notes are divided into sections at the top, and when you hover over them, more selections will appear. The tabs are divided into the woman's profile, obstetric profile, medical profile, social profile, screening profile, plan of care, communications, pregnancy outcome, and audit. The next tab is the consultations and admissions, where you can view any helpline contacts. You can view the booking to-do list and all information entered. You can view antenatal consultations, see hospital stays and visits, and lastly view postnatal consultations. The antenatal tab includes plan of care, observations, specialisms, procedures, investigations, fetal assessments, and pregnancy outcomes. This is designed so that anything entered during an inpatient stay or consultation will all appear here in one easy-to-view place. This is the same for the specialisms, where anything entered will pull through. In investigations, you can view investigation history and make more offers if required. Next is the intrapartum section. This is mainly covered by the Guardian system, but here you can see anything intrapartum that has been added against the woman, view baby information, and view reports. Then you can view the postnatal section, with the postnatal summary, observations, investigations, baby checks, plan of care, checklists, and discharge from care to health visitor. The final tab across the top is the green baby button, where you can view previously entered information, as well as record new information regarding the baby post-birth. On the main notes screen, you can also see several icons on the left-hand side. The risk flower in this instance is pink as the pregnancy is high risk. If the pregnancy is low risk, the flower will be green, and if data is yet to be entered, it will be grey. You can select the flower to perform a risk assessment and view active risks. Next is the meds icon, which should be used to enter any patient medications. The final icon can be used to add a new referral by selecting a referral reason and destination. There is also an Actions tab where you can view active actions, add new ones, and view completed ones. The three icons here are indicative of domestic abuse, social services involvement, and safeguarding. These icons will change depending on what is added in confidential mode. Confidential mode can be accessed by clicking the C in the top left-hand corner and authenticating. Once you go into confidential mode, look at the social profile where there are more tabs available to enter. These are highlighted with the flashing C to indicate that they can only be viewed in confidential mode. If you leave confidential mode, the C icon acts as a prompt to let you know that there are more hidden tabs. This brings us to the end of the functional navigation of K2 Athena. Thank you for watching.
Okay, come out of there. Okay, cool. So what we'll do is we'll do a little bit of navigation, but just a few points to start with. So usernames and passwords. So your username and password are going to be your normal, look at you, Claire, you're ahead of me, your normal network logins, so that you would use to log on to any PC or computer. They are exactly the same. The other thing that I'm going to just drop in the chat. So I have been working on these little toys. They are Padlets. These are going to be your #1 go-tos if you're looking for information about what it is that you need to do. And I'm going to put them in the chat because we can look at adding things to these as we go. So let me just put the links in for you. So there's two. There's one for Athena and there's one for Guardian. They're a work in progress, so we're populating them as we go, but there's a fair bit on them now. So I'm going to share my screen again for a second because we'll have a look at them. Okay. So basically, they're sort of online notice boards with information about how to complete a whole number of different actions. I'd point you towards this corner where you've got a search function. So these can work on PCs, laptops, on your phone, on tablets. They work in all sorts of fashions. The link is going to be widely shared. There'll also be laminated posters with QR codes all around the service, so you can just hold your phone up. So if, for example, you suddenly go, okay, how do I do an op note? You'll be able to, it will pull you up that particular section, and on there you'll have a video and a visual guide showing you what to do in that particular situation. So with these, if you leave a comment on any of these posts, or if you go all the way down to the end, there is a Q&A. If you leave a comment on there, it sends me an email letting me know that there's something that's missing. So I can then go in and add directly. So the next time someone needs to know the answer to that question, then we've updated it. So if we sort of work together collaboratively, I think probably within a few days, maybe a week, we're going to have covered most of our everyday routine stuff. Also on here are going to be links to all of the training sessions. So this one will go on here as well. So you can go back and watch those or point those towards your friends if you think anyone else needs to have access to them. So I'll stop sharing that for a second. We're going to do a bit more navigation. I just want to make a point as well. So when you watch that video, you look at the screens and you go, oh my gosh, there's so much information. There's so many things in there. Two things on that. One of them is it's structured data. And what that means is that if you enter the data in one place, it appears everywhere. So, for example, the midwife takes the obstetric history at booking, that populates that into every area within the system that's expecting to be able to see that information. So it's not like you've got to go in and go through it independently yourself. And also most of the processes that we're going to use are going to force you through the things that you need to see. So I'll share my screen again. And I've got a terrible habit, by the way, of not sharing my screen when I think I am. So please just do feel free to shout at me that I'm not. I won't be offended. So I'm going to log into the system. One of the things that we'll also do in this session is walk you through how you can access the test system, so you can go in and have a play for yourself. So let's do these tabs again for a minute. So you've got your locations here. So if you're in antenatal clinic, your clinics will be up here. I've been doing some work on trying to find the best way for these to appear so that they make sense, because a lot of the consultant clinics at the moment say antenatal clinic level 6, which is not helpful. But essentially, you will be able to identify your clinic. You would go in. This one has already ended, but you would go start clinic and it asks you for the start time and the end time. What it then does is it goes to IPM and it pulls forward all of the appointments within that time period for your particular clinic, and that's where your clinic list will come from. And then you can just click through and access each individual patient. Down here also, you've got your wards. So click through, for example, on Argyll. So these are our patients that we currently have admitted on Argyll. And you can click here on the left-hand side to either look at their inpatient notes, which is specifically just the current stay, or you can view notes, which is the full notes for that patient. Okay. And so other things that you need to see. So these are the doors. You'll hear a lot of talk about the doors. Claire Hine, I realise I don't have you on my consultant tab. I need to add you. Apologies for the omission. I saw your face.
Marianne's not on there either. Oh, she is now.
Yes,
Are they on there now? I was quite happy to get out of antenatal clinic.
Sorry, Claire, I need to add you though.
That's fine.
So essentially, the doors are a way of sorting records. So women can sit behind multiple doors. So they might be sitting behind the diabetes endocrinology door, but they also might be sitting behind IMO's door. They'll also be sitting behind their community midwifery door. It's a way of managing referrals, essentially. And we'll talk more about referrals in a minute. My desk is more for caseload management for community midwifery, but it gives midwives the ability to see all of the women currently under their care, what appointments they've got coming up. The only thing that may be of any interest to you in here, there is a way to look at all discharged women in the last 24 hours or 7 days, or also women that have delivered. Then you've got your reports section. So we're going to do a little bit of reports for you guys, because we're going to go in there to show you how to do blue box triage. But just as a sort of a quick overview, as you go through the system, you're going to see that there's lots of places where you enter data. So there's little circles or little squares that we're going to click. Any of those data points can be used as a basis for running a report, and it's really agile and really fast. So the example I always give is if in 6 weeks time, 3 months time, someone comes back to me and goes, Francesca, please can you tell me how many women came in preterm labour, had antenatal steroids, delivered before 34 weeks and had a baby with an APGAR of less than 5, I can run you that report in like 5 minutes. So just for your future reference for audit and quality assurance, I can run you one-off reports, or I can build you template reports that you might want to just go in and regularly run yourself.
So that tab, Francesca, isn't to see scans and things like that. That's
this
all
is the
about
audit
governance.
and reporting.
Okay.
Yeah, exactly. But I think it's super clever, and I think it's going to be one of my favourite parts of my job really soon. So I'm looking forward to that one. So that's a bit of quick navigation. The next thing to do really would be to sort of bounce into how you guys are going to use it on the everyday. But before I do that, is there any other questions that I can just pick up before we move on?
I just opened the Athena Padlet, and so there's nothing on there. Is that just because it's all a bit skinny at the moment, or is it because I've got to log into Athena before I can actually see anything on it?
So you should be able to see the same things that I can see on my screen at the moment. Can you see those or not?
Oh no, I'm just on my phone. I just opened it up on my phone.
So you need to swipe left because it will give you the first column, but if you swipe left it will move you to the next column, and so on and so forth.
All right, I'll have an explore.
Yeah, and also if you're on your phone, the magnifying glass is on the bottom bar, so you can go. I think that's how you're going to use it most often, is by searching.
Okay.
Yeah.
How do we get it on our phone, Fran?
If you click on the link that Fran's put into the comments section, Rachel.
Okay.
But on your phone. So if you
Yeah.
go into MS Teams on your phone,
Okay,
and click,
cool.
and yeah, it'll pop up.
I can also teach you how to save it as a link from your phone front screen, so it sort of functions a little bit like an app. I can add that onto the Padlet if you like, or send you some instructions just to make it a bit more readily accessible for you.
Yeah.
Okay, so let's go in and do some Athena. So we'll start with blue box triage because that feels like a sensible place to start. So in terms of managing blue box triage, we're actually going to use the reporting functionality for that. And so in here, what you'll do is you'll go to your routine reports and you'll choose for CLC triage. And you double click it. And then you're going to choose your start and end date. So admin team are going to run these for you. And provide you a printed copy, but if you want to go directly into the system, you choose the dates that you're going to cover. So say we're covering, let's go back a bit to make sure there are some bookings. And we'll go from the 9th until the 15th, see what that gives us. And then you're going to run that report. Yeah, because we haven't booked anybody for a little while. Bear with me. So if we try this one, obviously when we're live there'll be absolutely loads of these. There we go. So it gives you the list of the patients that have been booked, and then what you can do is you can click through and go and look at their records. So places that I think are going to be useful for you to look at generally, if you go into profile, you can see her pregnancy profile. So this is information that's been entered about this pregnancy. So she has some details in there. And you can go to her full obstetric history. Again, this particular woman hasn't got a huge amount of detail, but it would be completed in there after a full booking. The other thing that I think is going to be useful for you, so in your medical profile, you've got your pregnancy conditions. She doesn't have any identified. And if you go into your medical conditions, she doesn't have any identified either. Let's go try a slightly different patient. Let's see if we can find one with some more info. Jules Young, I think, has probably got some more information. Let's go in and look at her. So profile, pregnancy profile. So you can see there that you do have her LMP, and in her obstetric history, she hasn't got any previous pregnancy, so she doesn't have anything in there. Pregnancy conditions. Nope, she doesn't have any identified. Medical conditions. No, there isn't any for her, but you get the principle. You can click through and look at all of the information that was gathered about her at booking. So if she's in this pool, it's because the midwife at booking has decided that she potentially requires consultant involvement. So in the current process, you got in Salus that for consultant opinion. We don't have that grey area anymore. It's either they're booked for MLC or they're booked for CLC. And so this is how they would wash up at your door. So what you can do is you can go through and review the notes. If you want to see the full booking overview, you can go to consultations and admissions and booking overview. And then you can click down the buttons on the left hand side to see the relevant information about her. You can see risk assessments that have been completed for her and the management plan that was made by the midwife. So this woman's been used quite a bit by the looks of it. She's got a number of different management plans that have been made for her. Family history diabetes. She was then diagnosed as a gestational diabetic. She's had a conversation about pain management. And then it looks like this woman's actually delivered and she's had a referral to the perineal team. But you can use this information to make a decision about what you think we should do with this patient. And then on her type of care, she, as I said, has been allocated as CLC. So a number of different ways this can go. You can either go, yeah, absolutely, she's CLC, I'm going to leave her there. What you might do is say, for example, she's a lady with a history of a PPH, and what you would like, therefore, is you don't need to see her, but you're going to make a plan for venous access, 40 units of delivery, those sorts of things. What you can do is you can go into her profile, you can go to her plan of care and take to her management plans, which we just looked at, and you can add a new management plan. And so we're going to say this is labour and delivery mother. It was made when reviewing the notes. Plan form was for a case notes review. And you can just say, typing's been appalling today, so for CLC triage. So previous PPH, say 750 mils, so let's not go over the top. For venous access, plus 40 IU, not for clinic at this time. Okay. And then you can document who you are. That plan here hasn't been discussed with the woman because you've not spoken to her, and then finish. So that's then going to update in her management plan list. And you'll see in the moment, as we go through the antenatal clinic appointment, that the system's going to force that plan in front of everybody's eyes that's going to see her as she goes through her pregnancy. But then what you're going to do is you're going to go, actually, she can be MLC as long as she's got a plan. I'm okay with that. So you can go here to her plan of care and type of care. Whenever there's a red pencil in the system, that means you can enter data. So you can click on here on your pencil and you are going to say, actually, midwifery-led care. And the reason for change, so you can say, reviewed by myself, plan made for delivery, can stay MLC unless changes. And then you can finish it. You see it's changed up here, so she's now midwifery-led care. So yeah, if you're happy for her to stay CLC, stay CLC. If you want to put her back to MLC, then you can go into type of care and change it. So if you want her to stay as consultant-led care and therefore you want to see her in clinic, what you need to do is you need to add a referral. So up here, you've got your referral button, just lives up here on this side, and you're going to add a referral, and it's required, and referral reason is, what shall we say for her? Say, for example, these don't matter too much about it. Have I got much hemorrhage? Let's go for antenatal hemorrhage, and then it will give you all those options behind the door. So say you want to send her to high risk clinic, because we're in live, they're not pulling through at the moment, but all of those doors you can see on the front screen will pull through. You would choose high risk clinic and you would say it was yourself. And then what that does is it puts the woman behind the door. But you need to then also explain to the girls in antenatal clinic about why you've done that and say what you want to do with them. So referrals and actions work in tandem. So for every referral, you need an action. And so actions live over here. You're going to add an action and you're going to say arrange appointment. So description of action to be seen in clinic at, I don't know, 3440 plus USS, please. You can put a target date in there if you want to, you don't have to. And then pending, and then finish. So what that's done, as I said, that's put her behind the door. So the girls in antenatal clinic can then go through, look at that referral, look at the action and go, okay, great. Yep, she was reviewed by Claire. Claire's decided that she wants to see her. Let's book her for 3440 and book her for an ultrasound. So one of the questions that I've had is those sorts of situations where you want two things. Do you need to put through 2 separate referrals? No, because basically what you're trying to do is you're trying to get her to the antenatal clinic admin team. So just putting her there once with a well-described action about what you want will let both of those things be put on the radar and be booked for her.
And so where's that action tab? Where do you press add an action?
Up here.
Up
So up here
there.
in your left-hand corner. So you've got referrals here and you've got actions here.
Oh, that's that tiny little icon. Okay, perfect.
The one that looks like slightly like a Sabutio guy, that's a referral. And then your action there. Would you like me to make the screen bigger? Let's do that.
No, it's because I can't see your cursor moving around. Well, I can, but it's tiny. That's there. There we go.
Yeah. So referrals are there and actions are there.
Right, lovely. Thanks.
There are videos on this, by the way. Probably when you see it in video, it'll be more helpful. You're also going to have step-by-step guides, essentially. So you can just sit down to do it and go page by page by page. Then I click here and then I click here and then I click here. Okay. That's how you do that. Everybody feeling fairly confident about how to do that? Hopefully. Let's then do an antenatal clinic appointment. So I showed you on the front screen, you would go into Teams, choose your clinic from that front screen, give it a start date and an end date. It's going to pull you a clinic list. Because the test system isn't hooked up to live at the moment, I'm going to go the slightly long way. I'm going to go consultations and admissions, and I'm going to go new consultation. And I'm going to launch an unplanned consultation, but you won't need to do that because you'll be working off a clinic list. So consultation type face-to-face, this is a test. So the way that you navigate through this particular bit is you work your way through the buttons along the top here. So you're going to start by letting it know who you are and what it is that you do in life. Okay, and then click my next button. So what it's going to do is it's going to give me lots of that structured data that we saw on the other screen. So at this point, it's for review. You can't change the information, but you know, if you set this up before the patient walks into the room to talk to you, you can look at the summary of her pregnancy, what her risks are. So this one's a preterm birth, high risk. She's got a family history of type 2 diabetes. She's gestational diabetic. And as I said, this lady's actually delivered. We're just going in and doing an antenatal appointment. She's got a postnatal risk of an instrumental delivery. Type of care, any management plans that she's got. We looked at those on the other page. Mental health assessments, drug history, full obstetric history, anything that happened on previous consultations. Any previous admissions for this patient, and then results of risk assessments down there. And then you can go through to her observations. And so these will have been added for you by your MSW before they're coming in to see you. You can detail those down there. The thing that you might need to know, so these are like your sort of physiological observations. Down here, you've got a specialism window. So the only one that I think you guys are going to regularly use is there's a specialist set of screens if you're doing feedback clinic. That takes you through, you know, risks and discussions and documenting those. So I feel like you might be using that one quite often. I don't think there's any others that you guys are going to use regularly. There's Sherry's preterm birth over there. So if you're doing preterm birth clinic, you can use that one. And that just takes you through a set of specialist questions. But in this one, we're going to do a fairly routine appointment. And then in her investigations, so the system's hooked up to ICM. So it's going to pull through her blood results. So you'll be able to look at those. In your next window, you've got procedures. So if you performed a VE or a speculum or any of those things in that appointment, then you would be able to document those in there. I won't show you the VE screen here, I'll show you it later, but you can just add new and work your way through. And then you've got your assessments. So this is if you happen to want to run new assessments. So what you choose to do here is going to be as per your clinical judgment. But the one I do need you to do is the overall risk assessment. So this one is the one that has the impact on the colour of the flower for the woman. And it's part of our Ockenden requirement to risk assess at every interaction. So I need you to do this one, please. What you're going to do is you're going to add a new risk assessment. And it will tell you what the previous assessments have shown. And then next. And then pregnancy is high risk, yes, no. So for this patient, we're going to say yes. All relevant risk assessments undertaken and updated at this appointment, yes. Correct pathway selected, yes. Have I discussed the plan with the woman? Yes. Is the chosen place of birth still appropriate? Yes. And is the chosen type of place of birth still appropriate? Yes. And when you're filling in that screen, it is giving you bits of information down here to sort of prompt you. So is the type of care appropriate? She's MLC. So actually, we're going to say no because we're seeing her in consultant clinic. So pregnancy is high risk, yes, no, no. So we would run that. And next. Okay. And finish. And then your findings. So this is the bit that is closest to the current paper notes. So in your findings down here, you can click through and you can add new information in here because you've got a red pencil. So if you've discovered something you didn't already know, you can update it on this side. But broadly, you would document in here like you would on the paper note. So, well, today, plan for delivery discussed. Whatever else it is that you're going to enter for her. And then you're going to go to management. So in this one, it's going to give you the opportunity to add new actions and referrals. So you can add an action down here. So if in this appointment you decided that you're going to see her again, you can add an action to arrange a new appointment, and you can add a referral to put her behind a door so that the admin girls can pick that up for you. You can also make a new management plan, as we did previously, just on that button up there. Birth plans, I don't recommend that you guys really get into this one. It's midwifery rather than obstetric. It's lots of stuff around, do you want to get in the pool? Do you want to use balls? All these sorts of things. If you wanted to change her type of care, so we've said that she's CLC, so let's put her back. And finish. You can change that in there. And then in communications, so this is if you communicate with anybody else. So if you send a letter to the GP or if you get a specialist consult or any of those things, you can document that in here. So in terms of how letters can be added to the system, so we can upload them, but I understand the process is quite different depending on how you particularly operate. So if you do your own letters, I'll show you in a minute how to attach them. If you have admin support to do the letters for you, then please let me know so I can get in touch and let them know what they'll need to do to support you. So in this situation, I'm going to say we've talked to the GP and we've sent them a letter, and we're going to say advised of plan for delivery. And that is now and finish. So the thing that we haven't looked at in there, I realise, bear with me, the thing that we need to show you also. So when we went to observations, I didn't show you the symphysis fundal height chart. So that's in there when you're doing that observation on the baby. And the other thing that I need to show you is where the scan report will be. So the scan report should be in there. She hasn't got anything added at the moment. But yeah, your baby details will be in there. So your symphysis fundal height chart's there, and you'll be able to go in and look at your scan report. It will be attached in here. We might set that up in a minute so I can show you. But yeah, that comes under your observation. So apologies for not doing that at that point. So having worked your way through all of your screens, you're going to get all the way to the end. You're going to be happy and press the finish button. If you want to add any other additional comments, you can include those here. It gives you the opportunity to review everything that you've said, and then you can complete the consultation and say yes. Going to complete for me? Yeah. And so that takes you through how to do, oh, it's giving me a print. Don't need that. You can go away. That's how you would do an antenatal clinic appointment. So any questions arising from things we saw in there? You've all fallen asleep or I stunned you into silence.
Not sleeping. Thanks, Fran. I can't say I'm happy. I think it's really hard because it's quite small, and as I don't know, Claire point out, your mouse is quite small, so just trying to keep up with what you're clicking on is quite hard.
Okay.
I think when we actually use it, I think it will make it all feel a lot better. So it's fine. Yeah. But if I know right now, even though you've just talked me through it, I think if I saw someone in an antenatal clinic right now, I think I would be like, oh, what do I push? And I know if I was on blue boxes, I'd feel the same. But I think when we're actually in reality using it, I think it will be all right. I'm a bit worried about missing things still. So yeah, when you do the antenatal clinic consultation, does it automatically take you through all of those parts? So you can't skip over looking at the blood pressure, for example.
It will show it to you. It will take you to the observation screen and say, here are the observations. The only one where I do have a worry about, because I literally just did it myself, about that page where you've got the maternal stuff, the fetal stuff, and the specialisms because of the drop downs. So you could get a couple of screens along without looking at the symphysis fundal height chart, without looking at the scans. But I don't think your clinical judgment is going to allow you to do that anyway. But it might just be in that moment you go, oh God, actually, I realise I haven't looked at it. Where is it? So just as, you know, it is in observations. What can I do to make it easier? Would you like sort of A4 folders with step-by-step guides so you can go page by page on the way through? Or is it just we need to go and do it?
I think we just need to do it. I think
Yeah.
blue boxes, because you only do blue boxes one in 14 weeks.
Yeah.
And it's a bit like the gynae equivalent. I've forgotten how to use the system by the time I do it next time. So that blue boxes definitely need a user guide.
Yep.
I've got mine pinned on my notice board next to where I work, and I carry it around with me when I'm on Cal. Yeah, so the instructions for that can't go away.
No. So my thought was actually that's a folder, an A4 folder that lives in the antenatal clinic admin office that the girls physically give to whoever's doing blue box triage that week and go, this is how you do it.
Lovely. There's a question there from Charlotte about postnatal ward rounds. Are you coming on to ward rounds on Argyll?
Yep, we'll get that. Yep.
Great.
Cool. Fine. So we've done a bit of blue box triage, we've done a bit of antenatal clinic. Should we go and do an antenatal ward round? Because ward rounds work in the same way, whether they're antenatal or postnatal or whatever they are. So the thing that I need to talk you through, and you'll hear loads about it, is the SAFER review. So what's the SAFER review? So it's this format that K2 have come up with to do a structured clinical assessment of the patient, and that's you look at the situation, you look at the features, you look at the evaluation, you look at the risks, and you look at the recommendations. So when we were thinking about how we're going to use this system, I wanted to essentially have to teach you as few skills as possible. So SAFER reviews, you use them in triage, you use them for labour ward, you use them on the ward round, all the same format basically. And my advice to you is, if you don't know what to do a SAFER review, because it will get you to a decent plan of care. So let's show you what that looks like. Share my screen. Okay, so let's think about a patient that we've got on Argyll. So to get to your inpatients, you go to locations. And let's see if we've got an antenate on Argyll. Yeah, so we've got this lady here, Katie Smith. She's 28 and 2. She's a gravid of 1, parent 0. And so what you can do is you can go in and you can look at either her inpatient notes, which is going to tell you just specifically about what's happened on this admission.
And Francesca,
yeah.
do you have, but harping on with going back to Charlotte's point, but it's the same for antenatal. How will we know which patients need to be seen on each ward round?
So that process is not going to change. That's still going to be a piece of paper that's going to be.
That's still going to be a piece of paper. Oh, lovely.
Yeah. Yeah.
Thank you.
I can't digitize everything. Maybe one day in the future. But no, as it stands, you're going to get a list.
Lovely.
In terms of kit, so we're going to have workstations on wheels. Apparently, I'm not allowed to call them cows. Someone told me earlier.
That's because cow means gynae triaging. It would all be.
Does it? Right.
Yeah.
But yeah, so you're going to have these laptops on trolleys that are going to be on the wards, and you'll be able to take them with you to the bedside or wherever it is that you particularly want to go. And you'll be able to go in through your locations, look at your patient list, and pull up your patient's information. So this is related to the current stay. So the places I would suggest to you are the most helpful here. You can look at the inpatient stay details, when she was admitted and why she was admitted. You could also look at any times that she's called triage. You could look at her consultation history. And this one, her admittance narrative, this is going to be the closest thing to the paper notes. So anytime information is added anywhere for her, it's going to pull through automatically in here. So you can see that she was admitted to Argyll, she's had a VTE assessment, she's had a ward orientation, and she's had a couple of set of obs. And that's as far as we've got for her currently. On the next tab, if you go into management, so you could look at her management plans. You wanted to see them? Give me in there, she hasn't got any. But the thing I'm going to point you towards down here on your left-hand side is your SAFER review. So ward round is based around the SAFER review, so let's do one. So you're going to take a moment to look at her notes, look through her history, and then this is going to load for you. And so you're going to give the date and time of the review and who is there. I'm going to be a consultant just for a laugh. So you can document, number of people that are attending that ward round and the reason for the review. So for this one, it's going to be a ward round review, but you can see we can use a whole number of other reasons as to why we would be completing this review. And then in the features to review, you can choose which ones you think are going to be most appropriate. So for her, I'd suggest you probably want an abdominal palpation, probably not a VE, but I'll tick it because I can show you the VE screens, anything around membranes and LICOR, CTG reviews and Muse obs. And then next, it will tell you who her assigned clinicians are. It will tell you her history of abdominal palpation. And if you wanted to add a new one, you could click up here, go through the screens. If she's had a history of any VEs, they would be documented there, or again, you can add a new one. Any history around the membranes and LICOR, so she's had no indication of SHROM, so there's nothing in that one. Any CTG reviews that she's done. Let's do a CTG review upstairs. So if you've done a CTG review as part of this ward round, so antenatal CTG review, she's got no uterine activity. CTG started then, we did listen, event marker was given. The reason the CTG was started, so I think she's here for antenatal bleeding. Fetal movements felt by woman, yes. Baseline rate 130. That's appropriate for gestational age. It's not sinusoidal. Variability is 8. You have seen some accelerations. There's no decelerations. And so it is giving me the indication that this is a normal CTG. You can leave a comment if you wish. No planned actions. Discuss it with the woman. And we're going to discontinue monitoring because we're happy with it. We don't need to do anything else. So her CTG review is going to appear there. So because we're doing it in this SAFER review fashion, It means that if this woman actually then ends up on delivery suite 2 days later, every CTG review that's been completed during that stay is going to appear on this screen. So it's that history altogether. And if you want to see the details of any of the reviews, you can click on just the name there and it will give you the information. And then next gives you the opportunity to look at her observations. So you can see her mews are stable. She's not in labour, so we haven't diagnosed labour for her. Any notes you want to leave on your maternal assessment or your fetal assessment. If you're making a decision to expedite birth. And then you can look at all of her previous management plans, or you can also add a new management plan based on the conversation that you've had. Indicating whether you're escalating for senior review, if you're scheduling the next review, and finish. So that's it. If you go through the safer review scenario, it gives you the opportunity to look at all of the history around that patient and update a plan and give visibility on that plan for anybody else that might be looking after that woman.
So that's basically a pro forma, is it, for an antenatal review?
Well, so yeah, the plan is also to use it for postnatal review, but you choose different factors.
Okay.
The other thing though is that, so if you go into your admittance narrative,
yeah,
so what it's going to do is see it's pulled through all of that information from the safer review. So safer review, decision to expedite, no, fetal monitoring plan, uterine activity, CTG review. If you then want to add an additional bit of context, I'll do that again because that's pretty quick. You can go in and add a note, free text. You can explain. So,
okay.
RG for round.
Because there's quite a few people on this call today who are going to be coming in brand new and will have never done a post-cesarean check. Is there a post-cesarean check on here, like a pro forma with the prompts?
I will go and have a look for you. There is a specific postnatal assessment. We'll go through those screens.
Lovely, lovely.
So the other just thing to show you on notes is that, as you can imagine, if they've been in for a little while, this is going to get quite busy. So what you can do is you can go, I just want to see everything. I want to see all of the CTG reviews. And it will give you just a list of the CTG reviews and the outcomes, or any other thing that you just particularly want to see. Maybe you only just want to see the blood pressures, for example. And it will give you the series over time for everything that's been changed for her. Okay. Does that make sense?
It'll be fine once we're doing it.
Okay, fine. So let's have a look at Posty. So she is postnatal. So in our clinical assessments, I would still suggest that you do a safer review, because as I said, we sort of baselined that in for all of your assessments. But in your clinical assessment, you do also have your doctor's postnatal assessments. So let's go and see what's hiding behind this door. So time of observations now, antibiotics use. Let's say yes, she's on IVs. Current analgesia. Any postnatal complications or current concerns? Is the woman mobilizing? Yes, no. Is she eating or drinking? Yes, no. Is she passing flatus? Yes, no. Comments on the bowels. Uterine status, lochia. Wound site check, whether she's got any perineal trauma. Documentation of the perineal assessment. Discharge details. Is she suitable for midwife-led discharge? Is she getting Clexane? Is she getting TTOs? Has her discharge summary been written? Does she need a clinic follow-up? And have you created that referral? Does that follow all the bits that it needs to follow, Claire? Is there anything in there that's missing?
Well, that's wound, that's perineal wound. There are abdominal wounds. So I'm not sure it really matters so long as you free text which wound you're talking about. But there is currently a paper proforma for post-cesarean checks, and I think we're just going to have to make that, laminate it and put it everywhere so people can use that as a guide.
We can put it on the laptops if you want.
Yeah.
So one of my thoughts was there's going to be quite a lot of that going on, to laminate them and then secure them to the laptop so that you can just pick them up and look at them as reference points.
Oh yeah, that's a nice idea.
Yeah, okay, cool. So those are your 2 ward rounds. I don't think you guys have anything else in Athena. I think the next bit of stuff for you is Guardian. Oh, I can show you triage while we're in Athena.
What about prescribing? You said we prescribe on here.
Only for Synto in Guardian. Everything else is remaining on paper. And the only reason you need reason you need to prescribe the Synto is because you need to set it up for a midwife to be able to press the button to administer.
Right.
We'll see that when we go into Guardian in a second, but everything else is remaining on paper.
Okay.
We can't use EPMA in maternity, unfortunately, because it's got a global alert for pregnant women. So if you try and administer to a pregnant woman, it demands a doctor every time.
Yeah.
Which is not going to work, is it?
No.
So let's look at triage. So triage lives under locations, and it's in here. So these are your triage overview screens. So these are all of our women that are currently on the board with their BSOTS rating. We've got a couple of reds, I'm not sure why they're still there, an orange and several yellows. So the majority of the work here is going to be midwifery. And so what happens is the midwife works through these screens. They do the initial triage as per the BSOTS guideline. They do the ongoing care. And then if they're going to escalate to you, what you're going to do is you're going to come along and you're going to do this section. So if you're seeing a woman in triage, you have the opportunity to view the attendance notes. You can look at her helpline contact history. So she called triage on this one. And in her full notes, go back. Which one were we in this one? You can look at your pregnancy notes, so you can look at the full set of information about this woman, what her history is and what has happened with her. And then if you go in here, you can look at her initial triage that's been completed by a midwife. Let's go in one that's got one. So you can see that she's not had her full set entered, but you'd be able to see the muse, you'd be able to see the urine dip, conversations on fetal movements, abdominal palpation, fetal heart rate. You don't have to go in for these, they'll just appear on the front screen. You can go in and look at any relevant history, you can look at her current pregnancy. And then the bit that you're going to do, having reviewed that information, is you are going to do the SOFA review. So this is exactly the same process as you saw us do upstairs. So you're going to add new. And again, you're going to choose which features it is that you want to review. So this time I'll show you the VE screens just because it's interesting. So this one's going to be a triage review and features to review. Let's do abdominal palpation, VE, membranes and liquor. Fetal heart, muse. So there's her abdominal palpation. Let's add a VE. So these screens are going to be the same regardless of where you do them. So now we have consent, there's no chaperone, and we're going to do this to confirm the onset of established labour. No abnormalities detected. And then let's say she's 2 centimetres dilated, it's uneffaced, posterior, 2 centimetres, medium, loosely applied. no FSE, and no Lycor seen. Membranes are present. Presentation, phallic, and let's make her ROL. And the presenting part, -2, her caput, no moulding. Aseptic technique, yes, don't do swap count. And that's details of her VE there. Any information about the membranes and Lycor, any documentation of the fetal heart rate, any mews that have been taken, if she's been diagnosed in labour, maternal or fetal assessment, decision to expedite, no. Any new management plan, whether you're escalating for senior review, whether you're scheduling the next review, and close. So essentially that's the expectation of what you're going to do. You're going to come down, do a safer review, you're going to make a management plan for her, let the midwife know what your plan is, and then we can either transfer to the ward or we can transfer her home. And so what I will just show you, so if you take a phone call, the cool thing about this is if you, I don't expect you to answer the phone, but just saying, if you look, for example, at someone who I know has got some records, so any of the youngs should have some records. Let's try that one. What you should be able to see if they call triage again is the full history for that patient. So triage, not a neonatal call. She's calling from home. Okay, what's the phone number? So you'd be able to see on picking up the phone what the history is in this pregnancy. So it looks like this lady is delivered, information about how she delivered, any pregnancy conditions, any fetal conditions, hospital stays and visits, what happened to her, any times that she's called triage, and then it's going to run you through the BSOTS algorithm. But essentially any information entered means that we're going to be able to see it all the way through. But in terms of what you guys are going to do, you're going to turn up, you're going to review the notes, and you're going to do a safer review and make a plan. These ones you can document on the portals or on the workstations or on the PCs in triage. Any of those will work for you. So that feels like we've been up and down and around Athena. Shall we go and have a look at labour ward?
Can I ask another question, Fran? Sorry.
Yeah.
If, say, a patient arrives in triage and it's one of those awful situations, mum's bleeding, fetal heart rate's 50, and obviously I haven't got enough time to go onto the computer to write the notes that I would normally do in like 2 seconds, which might involve present and the time of my twos. How can I do a quick entry?
You can just take her straight to labour ward, and she'll be admitted to labour ward because that's what we would do with her, right? And then we would admit her on Guardian, and then on Guardian you would go into the notes and you would document why the triage wasn't completed, because it's still in the same record, isn't it?
But presumably if you just whip her straight into theatre, it's all going to be retrospective notes.
So we're still going to be documenting on Guardian in theatre, because there's not going to be any paper anywhere. So you have the opportunity still to go back retrospectively and add that documentation. You can go back and go in at any point, but it's not really going to be any different from the situation now, is it? So it's going to be the same. That's what happens now. We don't write in the notes and then go back and document.
No.
So do you have to do your Athena notes and then your guard? So say you did like some quick antenatal care before you ran to theatre, then you do your Athena notes and then you do your Guardian. So if you see someone in triage and they're antenatal, but you take them for an abnormal antenatal CCG or something, that bit's going to be in Athena, and then the theatre notes will be in Guardian.
But it's all the same. It's all the same database essentially.
Okay.
So they present as different systems. However, in the bigger picture, anything that you documented in Athena is visible in Guardian, and anything you documented in Guardian is visible in Athena. So when you go into her admittance narrative, it doesn't matter whether you were in Athena when you added it or Guardian when you added it. It's all still one complete record.
Okay.
Yeah.
And how about if I do what I sometimes do, which is make a horrible mistake, and I realise then I'm filling out, my husband's laughing at me, sorry, and I realise that I filled out the details for the incorrect patient. What do I do?
When you fill the details for the incorrect patient. Okay, so it's going to be quite difficult to fill out the details for the incorrect patient, though. I mean, it may well still happen. But what you can do is, in that situation, let me show you. You would go into Athena. So let's go and find a patient with some entries. Oops. Oh, hang on. So let's go in and find a patient. Let's go to a CDS patient. And so view the inpatient notes. So what you can do in that situation, so you can go to your admittance narrative and you can audit it. And it should give you the opportunity to delete. Where is it? I'll go and have a look and get you the answer on that, Rachel, but there is a button that you can press. And what happens when you go and select that note is it ends up struck through. So it's got a full audit trail. You cannot delete information out of the system, but you get a strike through. But yeah, I will go and find out that answer for you and I'll let you know.
Thank you.
Shall we do some Guardian? Cheeky bit of Guardian?
Yeah.
Okay.
Yep.
Cool. Okay, if it's going to let me in, I have to go the other way. Let's go this way. Okay. So we're going to admit to CDS. Bed number 1. Let's say that we have got Margaret Young. So when I'm showing you the screen, it's going to ask to enter the password a really annoying amount of times. Just to be clear, when we use this in real life, you'll be able to use the fingerprint on the portals. If you could therefore please get yourself a fingerprint sooner rather than later, so any band 7 on labour ward can support you with that. You can just go and get fingerprinted, if that's okay, please, people. So these are screens that you might recognise because part of the system is already live on labour ward, which we use it for central monitoring. So the admission and the trace you may recognise. The partogram will be new. So the partogram just looks, it's just the paper record essentially, transcribed into a digital format. I might just pop a VE on because it's cool the way it displays. No, sex labour progress. No. Let's put her in labour. Let's say she's 5. Central, 2 centimetres, medium, well applied. Oops, fissy applied, nope. Absent after SHROM. Do that. And you have to be nope. And cephalic, and that one. And done, and yes, and no. And that one. Okay. Okay, so go back to the top of my partogram. So you can see on there your records of the fetal heart, details about the contractions, details about the maternal heart rate, details about the blood pressure. those things will come across, and any information about analgesia. So she's got an epidural in situ. You can see the Muse chart directly here. So these are all on the touch screens in labour ward, and you can click through on there. And then you've got the plan. So Guardian works on the principles of it has ideas about care that may be relevant for the woman that we're looking after based on her current situation. So this woman has got lots of things going on. She's got 1 red Muse score, she's got PROM, she's on oxytocin, and she's got an epidural in situ. Which means that it has thoughts about what we should be doing for her. So it's prompting for a CTG review, it's prompting to turn up the Synto, it's prompting to enter the fluid balance, to do the pulse and contractions, to review the epidural, pressure areas assessment, take a temperature, any number of things. And then if these are not done, it will start alarming over here to say that they were due some time ago and they've not been done, and also has an indication of upcoming events. So what's interesting or useful for you guys is the button over here with the custom plan event. So if you go in and do a CTG review and you go, my plan is I'm going to come back in 30 minutes, and then at 24 minutes, the emergency bell goes and you run off to theatre. If you have put in the plan for that action at 30 minutes, that item of the plan will be visible on the board in labour ward. There's a larger realm of visibility as to what's needed to happen. So say that is our CTG review, time of occurrence. So time of occurrence that you make the plan, and then when you want to complete that, and it is a CTG review, and finish. We're going to pop this one in. So now your CTG review has entered itself along here. So again, it's a prompt, and if that's not done, the system is going to start alarming over here and encouraging the midwife to make sure that that action is done. In here, you've got your notes section. So this looks just like the admittance narrative that we were talking about upstairs, and it works in exactly the same way. You can just click add a note, free text, and you can add your contextual information about what you would like to document for your care and your outcome. So these are the screens. You don't need these screens in Guardian, but we'll use these to document the information around the delivery. And then the one that we're going to use an awful lot is the actions button up here. So this is quick access. So if you walk into the room and you want a quick understanding of what's going on with the woman, you can use your safer buttons down here. So that gives you your situation, features, evaluation, risks, and recommendations. And if you go in here, you can look at everything to do with triage, any of her management plans, any of her safer reviews, risk assessments, antenatal assessments, Muse, anything along those sorts of lines. You can document those in here. I will just tell you about a conversation that I had with Steph Lamb. Rachel, I know you've heard this, so apologies for repeating it, but it's worth mentioning. So Steph and I had a conversation about the safer review, and she said to me, well, yeah, but if I want to prescribe my woman Synto, I can come in and I can do a VE and I can make the description. I can make the description, and then I can just add a note explaining what I've done. And I said, of course you can. That's absolutely as per your clinical judgment. However, if we then need to look for whatever reason at the log around what happened in that particular episode, if we need to review the quality of care, what we can see from the record is that you came in, you did a VE and you prescribed Synto, which is fine. However, if you did that as a safer review, even if you didn't do anything with the information that was presented to you, in the audit log, it's going to show she came in, she thought about the membranes and lichens, she looked at the Muse, she looked at the fluid balance, she did a VE, she wrote a prescription for Synto, and then she updated the plan. So just as a point of how you might want to use the safer reviews, I highly recommend them because they provide that sort of backbone in the documentation to your clinical decision making. Just thought I'd share that with you. So let's talk about Synto, shall we? So over here, you won't need to necessarily do too much for this, but what I need you to do is to support the midwife. So when we go into the Synto section, and let's add new, there's a bit that we can't do. There's a bit that we need you to do. So as the prescribing clinician, that's going to be me. I'm going to make myself a consultant just for fun. You're going to indicate the reason for the prescription. So let's say she's poor progress in the first stage. Standard regime. And it's this bit. So you can't go through to the next screen without entering something on the advice on stopping oxytocin, and that's not advice that we can give. So hyperstimulation, non-reassuring CTG, decision for section, and then finish. So what that then does is it creates this ability for us to go in and commence the infusion. But we can't do that initial bit to set up. We need you guys to do that. And we are still, as I said, we're still documenting the prescription on paper, but I need you to do those couple of screens. Also, it's about Ockenden actions of us, you know, ensuring that we've had medical review before we put up the SINT. It covers us on both sides. Does that make sense?
Yeah. Going back to a question that's popped up, will blood taking remain the same? Will patients still have stickers, and will we still need to print stickers out? I presume we will. That side of things, does all the...
So we still need to order them on ICM, and then the results will come back into K2. So we order them on ICM, but we can look at them in K2.
And will patients still have stickers?
Somebody asked me this question the other day, and I was like, that's going to be an absolute landslide of a change if we get rid of stickers.
But how will they carry them?
So they are still going to have small cardboard folders.
Right.
The answer I came to was that we are going to need stickers because we're going to need stickers for the drugs charts.
Yeah, good point.
But other than that, I can't really think of anything that I'm going to need to put a sticker on.
No. Yeah. Histology pots, but we don't need a lot of those.
No. So, but I think like one pack of stickers or one set of stickers is probably going to last an entire pregnancy nowadays.
We still use stickers to stick on the scan forms and things. So they are still pretty useful. The other thing is if you're just running down the corridor with a patient's details, you don't really want to be like running to theatre, you know, to try and do a sapphire form, trying to scribble all the. So you do need some stickers. It is pretty helpful.
Yeah. In terms of the scan forms, Marianne, do you mean the green cards?
Yeah, that's all going to be on there, is it?
Yeah, we're not going to need any of those.
Okay, cool.
You just put through an Athena referral.
Okay,
but yeah,
cool.
also theatres is another good point because we're still keeping the theatres pathway. So we're going to have to put stickers on drug charts and those. But there's not going to be many things.
And sapphires and things. But also if you're in a really terrible hurry, you usually end up just running down with a sticker and just giving it to them.
Yeah. Okay. What else might I need to show you guys on labour ward? I feel
the
like
post-op, the op notes, are they on here?
Yeah. I'll just make sure that I've covered all these bits before I get to those because they are a bit complex. We did a antenatal CTG review, didn't we? Do you want to do an intrapartum one as well, or are you happy that you know how that works?
I don't know how any of this works. I really feel like I'm just going to be guided by the midwife.
Yeah, fine.
Who's on labour ward. I'm just going to be happy if I get into Guardian and if I've got fingerprint access, and then I'll just have to make it up.
You are going to have support on the floor 24 hours a day for 3 weeks.
Yes.
After go live. You're going to have super use and sort of point you in the right
fantastic.
direction.
Yeah.
And me sobbing in a corner, probably.
Undoubtedly.
Well, they're not letting me out.
IV gin. Yeah, it's fine.
They're locking me in a room for like 4 days after go live. I'm not allowed out. I have to sit in a control centre. So that's going to be fun. Anyway.
Is that,
so
Fran, sorry, is that support, is that on just on labour ward, or will it be on in clinic as well?
So clinic is a slightly different situation. We need to have some specific clinic super users. So I think your super users there are going to be Jane, and they are going to be Jackie, and they are going to be Simone. We did try to get some MSWs to come forward to provide some additional support, and we didn't get any take on that. But yeah, I think it's going to be midwifery led, the clinic support essentially. But the bit of the system that you need to use for clinic, I know it seems massive to you, but it is fairly small in the big scheme of things. Once you've done 5 or 6, you will be absolutely flying, because it's the same things again and again. It's the same places and the same bits, but you'll have midwifery support for that. On the floor, a little bit different, because you've got the digital transformation team as well, who have been doing the midwifery training program. So those guys have been eating, sleeping and breathing Cato for about the last 6 weeks. So yes, they are your additional floor support as well. Also during the day, you've got digital teams. So you've got me, Michelle Hambley and Linda Watts on the floor to be able to assist you too, providing we're not on the floor ourselves. So shall we do your op notes? Let's do those. So I'm going to come out of Guardian to do those, because I recommend that you do them in Athena. You can do them in Guardian, but it is quite clunky. So you would be able to do them on the PCs in Triage, or on a workstation on wheels if you want to acquire yourself one.
And once they're done,
Yeah.
so from regarding a postnatal review on the ward perspective,
Yeah.
would we have to go into the separate op note, or would it all just be within her profile, would it?
Yeah, it will be in
Yeah.
her delivery summary.
Yeah, okay, lovely.
So if we go into our locations, let's go to CDS. Thing that I need you to know about op notes, I don't quite understand the logic, but just so you know, K2 are of the opinion that caesarean sections happen to women and instrumental deliveries happen to babies. So that means when you need to go and document the section, you go into the woman's notes. When you document a forceps or Bontus or whatever, then you go into the baby's notes. So in terms of doing yours, so let's just go through that bit again. So we've gone through Athena from locations, we're on to central delivery suite. And so we've got our lady here, Emma Beckham. Let's deliver Anne Beckham actually. So you're going to view her notes. And the intrapartum bit that we're going to do. So this one is a double hander. So what needs to happen is the midwife needs to do this bit for you, but she can do that on Guardian in theatre. So she can do the delivery because she has to tell the system the type of delivery. So she had one baby, it was due today, she had it in theatre. And let's say that this woman had a section, she did have some pain relief, she did have one-to-one care. You guys don't need to do these. This is going to be midwifery stuff. Okay, none. Next. Reviewed comment and finish. Okay, so the midwife has done this bit for you. So she said, yep, this woman has delivered. So because she said it's a section, that now means that your op note has popped up over here. So what you do is by the time you get there, this will already be here. And you click your C-section and you go into your notes. There's an awful lot of screens here. So in terms of what happened during this delivery, so whilst you were, removing the child, the midwife in the room will have been pressing buttons, prescribed buttons, as you can see here, with the decision to deliver time, anaesthetist, so on and so forth. when the checklist was done. So what you can do is you can directly bring those into your op note. So we're going to import all of those. Okay, so she had a Cat 2 section. Yes or no, consultant present, yes. Let's say that I'm a consultant. We had consent, it was written. The indicator was, what should we say? Let's not go too hard on her. Let's say that we did it because of delay in second stage. And then who the surgeon was. And I'm going to be a consultant for the evening. All of these bits of information, because your midwife has already pressed the button for you, you haven't got to enter any of these. It already automatically comes through. And again, with your anaesthesia, because your midwife will have pressed the button for you, you don't need to enter anything on that. Yes to antibiotics. If there was a delay, you're going to indicate what your delay was and why. And then your incision. And so let's go for this one. And again, if your midwife had entered knife to skin, that would be there for you. This one, no. Was there a previous scar to excise? Was there difficulty opening the abdomen? Did you have to dissect the bladder? Did you extend the uterine incision? That's all of those bits. Where is cervical dilatation at time of section? So let's say she was 9. And then finish. So that's your notes part. And then you need to go down here and do your conclusion. And then this is about the tidying up. Test. And is the cavity checked and cleaned? What sort of repair you did? What material you used? If you did any of these things, I wonder what it's going to let me get through. Okay, all right, so it's going to force me to answer some of these questions. So I'm going to do that one and that one. Apologies for my terrible obstetric practice. This is not my dance space. Whether the uterus tubes and ovaries were normal, any tubal ligation, any ovarian cystectomy, any other procedure. No.
Bit of a question there, Francesca.
Yeah.
How will the midwives know, actually, how would the midwives know if the sutures are dissolvable? And also, we don't do a tubal ligation generally. We remove the tubes. That's quite important.
So these screens are your screens. So the midwife's going to be doing these. Sorry, the midwife's not going to be doing these. You're going to be doing these. So the bit that the midwife's going to do is that first bit, the birth bit, and then all of these screens that I've showed you. So I'll go back and show you again. So in terms of what happens, so the birth bit is done by the midwife. That generates your C-section screen over here. And then all of this stuff on here is you. About ligation.
Yeah, but where's the bit where we say these stitches don't need to be removed or these stitches do?
So you would put that in the management plan. Okay, next.
Where's that?
Just keep going, get through to the end. So say it's this one. And these ones, so all of these are yours. Cavity checked, yes. They're not abnormal. There was no tubal ligation, there was no ovarian cystectomy, there was no other procedure. The question about tubal ligation as to why it's there, it's a point for coding. So I trained coding the other day, and apparently this is one of their points of data that they have to return on. All of the things on this screen are.
So if we do a bilateral salpingectomy, do we put that, do we just annotate that section or write it under other procedure, or does it not really matter as long as it's there?
You'd put it in your note at the end. So when we get to the last screen, you'll see where you can give that bit more detail on the things that you might otherwise. So no Wrigley's, yes to delayed cord clamping because we're good like that. And then your procedure comments. So you can write what you currently write in the paper notes here. So any of that additional detail can go in that part.
Right.
And is that where we put Myrena in as well, and procedure comments?
Yeah.
Yeah.
Thanks. And where's the EBL? I didn't see an EBL.
So that's again a midwife job, but I will show that for you.
Okay. So again, going back to those sutures, we have to remember to write down whether they're dissolvable or not, do we? Because this is something we get asked all the time, and we get pulled up on it all the time.
Let's have a look. So you'd put it, I think, in your post-operative care instructions here.
So we'd have to explicitly write that, because normally we just write Novosin quick, you know, whatever, blah, 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 and Monosin or whatever, presuming that everyone would know that a Monosin is dissolvable. But actually, do we need to write Monosin absorbable suture?
I think you don't even need to say the name of the suture. I don't think you just need to say if it needs to be, you know, for the purposes of the people reading it, the community midwives and the SHOs, it's just going to be what needs to go on the TTO.
I'm just thinking if there's like a wound breakdown and they look back at your notes and they want to know if you used like a
what it is.
Do you know what I mean? You
yeah.
want to document what you actually used, but we have to explicitly say like non-absorbable or absorbable, because that's not going to be presumed that everyone will know.
Well, so on those previous screens that we've gone through, we indicated what you'd used for closure. So if you needed to go back and check, that's the place where we would find that information. Here, your post-operative care instructions are the care that you're handing on to the rest of the team. So you wouldn't need to say Monosin or whatever, but dissolvable would be really helpful. I don't know what Monosin is.
Yeah.
Then next. Any advice for the next delivery? Any additional comments for the next birth? And advice for delivery.
So if you put stuff in that's like advised never to have another birth ever again, very dangerous. You know, like it was a bit of a car crash. Then would that come up in the next antenatal? That's linked to Athena and will come up. So say when you see this person in the next antenatal clinic and you're just like, oh, let's review your previous notes. Oh, it said you shouldn't have got pregnant, blah blah blah.
Yeah.
Like,
she's just going to be blocked from Athena, Marianne.
She's just going to be
won't
like,
be allowed an account.
So
you won't be allowed to register.
Yeah. Okay.
But yes,
you made a pass go.
Exactly that. When she turns up next time, you'll be able to go and view her previous pregnancy notes, and you'll be able to look at her op note and be able to see that history.
Okay.
And the question about EBL, so that one is included in third stage, I believe. Oh no, blood loss record. It's down here. So this is really, as I said, it's going to be more of a midwife job than a you job. You can certainly write it in your op note. But the midwife is going to go in and she's going to complete this wizard in order for the figures to appear in all the right places. So say she's had a 400 ml loss there. Total EBL checked and confirmed, yes. And what that does is it then populates the record in all the various places for the postnatal assessments and so on. It will, pull it through. So for you guys, yes, write it in the op note, but tell the midwife because she's going to go and do that visit as well. Okay. So if it was an instrumental delivery, you would go into your baby button. So I don't have a full baby button because we haven't done all of the screens. So let's quickly go and do that. Though actually, I would need to do it on another patient. I will just show you where it is. Short delivery, Susie Cole had. Okay. I feel like she had an instrumental delivery. What happened with her birth? Oh no, she had spontaneous vaginal. Well done, Susie. What did you have? actually had a section. I might just have to go and quickly deliver a baby to show you how to do it. Okay, so we're going to go into the notes. And so we're going to go to intrapartum. We're going to go to birth, about her delivery. And so number of babies was 1. She had a baby in theatre. ADD was today. And so transfer to delivery suite, no. Pain relief given, yes. Labour complications, none. Yes to all of these lovely things. None. Oh, she's already got some sort of entry. Okay, she's actually not very helpful to me. Apologies. I need to find you an instrumental woman. What about if I go in here? Okay, sorry. Apologies. Right, so I need to tell them how many babies. We can do that. So only 1 baby, delivered in theatre today. Yes, went to delivery suite. Pain relief given, yes. Next. Okay. Finish. And then if I go in here to my baby delivery information. Again, this is not a bit that you guys are going to need to do. So let's say that she's going to have forceps. Didn't require resource, no shoulder dystocia, and finish. So what that does, so again, your midwife has gone and set up the type of delivery. You've now got a green baby button up here, and sections happen to women and instrumentals happen to babies. So up here on your screens, you've now got the ability to document an instrumental delivery. So you can go in here. Again, you can pull through your scribe contents. Time of decision making, if the midwife had done this in theatre, then that would be there for you. Instrument indicators, malpresentation, delivered in theatre, you did get consent. I made the decision. And I've made myself a consultant. Who performed the procedure was me. That one. All of these stuff will pull through for you. Again, if the midwives press the button. So she's transferring now. And this is where you then document your procedure. So the action time was now. Bladder emptied. Instrument applied was Wrigley's. Hewlands. Manual rotation and lift out. And then next. And then it's going to ask you for a load of information about the delivery. So all of these times, maternal birth position, any information about LICOR, lie, presentation, position, moulding, important procedure details, and what your follow-up care plan is. And then that should cover, and then just your conclusion. This is the bit we didn't do on the other screen. So important procedure details, antibiotics prescribed. She's had diclofenac. And we are done. And that's your op note. Is there anything else that you haven't seen that you think, Francesca, how do I go and do that bit?
So presumably manual removal, repair a 3rd degree tear, that's in on 3rd stage, is it?
Let's go and have a look. So manual removal is under, if we go into birth, and where is it? So I saw it. I think it's where, when you go into the delivery, you have to indicate that you have it. that one. Let's see. No, I don't know the answer to that question off the top of my head. Nobody's asked me that yet. I will go and find you out the answer.
Maybe it is on third stage. Why don't you? Can we
You
click
can
on
click
third?
retained placenta there. Would that help?
Oh, in the birth section. Oh, there it is. Look. Yeah, you're right, Claire. Sorry. Third stage retained placenta.
Yeah.
And next, and it's in there. Documentation. It's very, very simple and straightforward, though. It feels like it should be more complex than it is.
Yeah, and so with regards, going back to that instrumental, when a baby is born, it appears as a patient on delivery suite, does it? On the Guardian, that's how we enter that.
It still sits on its mother's record, so you go into the mother's record and you press that green baby button at the top.
Press the green baby button. Okay.
Yeah. Shall I go through and I'll add you all so you've all got access to the test system, so that you can go and have a play.
Yeah, and so will the Athena icon then pop up in my G drive, because it's not there at the moment?
Nope. So next week, once we're live, it will appear in your software center.
Software center.
Yeah, it'll appear in your
So
software center.
how can we have a play if we can't access it?
Because I can take you into the test system, which is in the G drive. I can give you access to that, but the live system will appear in your software center from Monday. Dun, dun, dun.
Well.
Cool. Any more of the things that we might need to cover? I appreciate it's a huge amount of information.
Sorry, Francesca, do we have to ask you for access to the test system then on the G drive?
So I will go in and add you to the test system on the G drive. What I will just show you very quickly is how you find it.
Okay.
So once I've added you, I just need to put you in that user group that can get in there. And then what happens, I feel like I don't currently have G, so that's not very helpful. But what you would do, I'll make you a little video and put it on the Padlet, but essentially you go to the G drive, there's a folder called K2 Athena Guardian. You go in there and there's a folder called Connect Athena. You go in there, you find the little yellow icon, and it will ask you for some password information, which I'll put on the Padlet for you, and then you can log in. I'll do you some step-by-step instructions on a video when we get off this call so that you can get in there.
Cool, that's great. But so in terms of actually properly logging onto the system, we're not going to be able to do that until the day it goes live. We're literally going to land on the floor and all log in. Is that right?
Yeah, but in test, I'll give you test passwords so that you can go in and play like I've been doing today. But in the live system that hits next week, it'll be your usual logins. I'll just take a minute to go through the questions. Okay. Rachel, you can't get into the Padlet. What happened? What happened to you?
It just tells me I'm not allowed.
No. Okay, fine. Will patients still have stickers that we can use to take their details to list to run blood gases? Yes, is the answer to that. We've agreed. Early pregnancy women on Ocean or in EPU plan. So yeah, I'm aspirational to get EPU and gynae generally on board. So I'm going to soften them up by giving them Microsoft bookings to manage all of their routine appointment stuff. And then it's not on my immediate radar, but within 3 to 6 months, I'd like to see EPU and gynae using it as well. How do GPs act?
Sometimes, sorry, Fran, just on that point, sometimes the admission onto a gynae ward will be really relevant for their obstetric stay. So say, for example, they come in, they're 13 weeks, they've got short cervix, they have a cervical suture put in, everything's gone onto paper. How can we then access that when they come in? Are we going to be blind to it? Are we just not going to have any awareness? If someone has been kind enough to add it onto their notes, then great. Yeah, I think it's probably a fairly urgent ask for EPU and Ocean. I think if we're going to start using this from the point of booking, I think it needs to be used from the point of booking.
Says risk head.
Yeah, sorry.
But that's a really big conversation, Rachel, because one of the concerns in this project, I'm just saying, one of the concerns in this project is about scope creep. So the powers that be want to limit the usage as much as possible. So I'm very, very happy to go and take on that conversation if you want to back me up on it. But
I will back you up. I think it's more of an obstetric risk than a gynae risk, to be honest, because actually in gynae it's still keeping them safe. What's becoming unsafe is their care pathway as things advance, with being blind to what's happened to them in early pregnancy.
Yeah. But they want gynae in line with the hospital's digital transfer, don't they? Because they're all against K2. They've got their own thing going on, which hasn't really come off the ground. So they're going to want gynae enveloped in that, and they're basically going to want us to come off at K2, aren't they? In a couple of years' time, when the whole hospital goes.
Yep,
which is really crazy.
But I absolutely see your point, Rachel, and I'd be really happy to have that conversation. But for the moment, I have not been able to win that battle.
I'll shut up.
Other questions. This is only for OBS, so gynae still on paper. Yes, as discussed, gynae still on paper. Do we need to email you for ask for the test access automatically? So yes, I will just go and add everybody that's in this session in a second. When does K2 go live? A week today, next Wednesday. A week today. Yes, 22nd. So 9:30 a.m. on the 22nd, providing all is good, providing we don't have any huge last minute technical issues. 9:30. A question though about clinical cutover, because a few people have asked me about this, so it's probably useful to you. What happens if you're in labour at 9:30 a.m. next Wednesday? So if your delivery episode has started on paper, we're going to complete you on paper, but your postnatal paperwork is going to be done on K2. So you're just going to labour on paper, then you're going to go digital. You're going to be digital for the whole entirety of your episode. If you have already delivered and you're sitting on Argyll or TCW on the 22nd, and you've got your paper in your hand, you are going to complete on paper. You're going to do the rest of your journey on paper, happily go off into the world, never know what K2 is and never need to know. If you are an antenate that's sitting on Argyll at 9:30 on the 22nd, we are going to transfer your care onto K2, create you a digital record, write in your paper notes to say, please refer to K2, and on you go.
But they'll have to carry around their notes with them as well, won't they? Yeah.
Yes, they're going to retain their notes.
They won't be retrospectively populated. No.
Yeah, because it's all on an app, isn't it, on the patient's phone?
Yes.
Yeah. Okay. Okay.
Dun, dun, dun. All right, cool. I will go away immediately. As soon as we come out of this call, I'm going to add you all into the test system. I'll make you a little video with how to get into the test system. I'll put it on the Padlet for you, and I'll send you out an email with the details.
I do have one. I do have one more. Sorry, Marianne, you carry on.
Oh no, I was just going to say, Rachel, the Padlet works. I just got it up on my laptop, and it works perfectly. I just think I'm going to carry my laptop around for like a month. Just because I'm really, really concerned about like shit computers and none being free and everything else. So if I just have my own laptop, I can just like, and if I have those things on it, the idiot guide, I can try and make it up.
What do we do about med student reviews? Do they have to be entered on Athena?
Well, tell me about med student reviews.
Well, Maya Wilson might be a midwife to speak to because she looks after all the third years, and they are reviewing patients every day for their own education. But so they're not making clinical decisions, but the fact that they've met a patient does need to be recorded.
Do we currently write it in the paper notes?
I know, actually, maybe not.
No. If we don't write it on paper, then we're not writing it digitally.
Okay.
How do you feel about that risk lead, Rachel Roberts?
I think that's absolutely fine. I'm very happy about that. I think if they're on a ward round with us, then sometimes we might write their name in. But I know what we currently do is, and for a lot of times, if I'm not quite sure what someone's called, I might know that their name's Amber, but I'm just going to write Amber, med student. I'm not going to say what's your full name. So actually, it will probably never stand up anyway. I think it's fine. Let's not worry about it.
Okay.
Fine. Okay. All right, folks. I shall bid you a very happy evening and go and do some diligent administration for you. Rachel, if you still can't get into the Padlet, then please do drop me an email. I'll go and see if it hates you for any particular reason.
Okay, I'm sure it's just me.
All right, guys, thank you so much.
Thanks,
Thanks, Fran.
The recording from this will be available in the chat. As I said, I will also add a link to the Padlet. So if you come across anyone that needs to watch back the recording, that's how you can share it with them. Okay, cool. All right, guys, see you later.
Bye.
Bye.
Thanks. Bye.
Bye.
afternoon.
Here we go, get through.
Oh, do you want me to go?
Oh, you're cooking tea, sweetheart, aren't you?
It's in the oven.
It's in oven.